Hello everyone, welcome back. I'm Dr. Mark, and today we're going to see the criteria to make a diabetes diagnosis. So, how do we know which patients do have diabetes and which patients don't? So, let's check out this information. Of course, to keep the blue monster in check, we need to first diagnose or get the diagnosis of the disease of diabetes. So, today we're going to look at the procedure that we make to know if a patient has or doesn't have diabetes. So it of course depends on glucose levels. As we explained in previous videos when we talked about what is diabetes, that I will leave a link on the top right corner so you can check it out. But diabetes is a disease where our hormones are not properly working, whether because we do not have one of them, insulin, or because we have a lot of hormones fighting against insulin, called the counter-regulatory insulin hormones. And so the final product in our patient is a very high glucose level that will lead to toxicity to our cells, slowly killing them, or if we have really high levels, to very severe complications that we will talk about in more detail in future videos. So the diagnosis for diabetes depends on glucose levels in our bloodstream, in our blood samples. So we have two main studies or two types of studies in our blood that lead us to the diagnosis of diabetes. We have plasma glucose, that is, right now I'm going to check the level of glucose in your blood. And this is very good because, for example, if we have a patient with an emergency where we are suspicious of a severe complication of diabetes, it can tell me right now how bad is the hyperglycemia in my patient, so the high blood glucose level. It's also a very fast study. It's really good. The weakness plasma glucose has is, of course, we eat and then we fast for a couple of hours. So it's a very variable level. We may have very high levels after eating and then normal levels when we are not eating. And the patient still has diabetes, because what causes the harm to our patient is not that glucose is in a very high level all the time. It's those peaks, very high peaks, even if it's just one a day, may be hurting a lot the tissues or the organs of my patients. So since plasma glucose is very changing from 1 hour to the other, we have another study that it's much more consistent, and it's glycosylated hemoglobin or glycated hemoglobin. So here what we are using, or the principle behind this test, is glucose likes to stick to proteins. That's the mechanism of toxicity, the way it slowly destroys the proteins and then the cells of our bodies. So we have a very frequent protein in our blood, in our bloodstream, that's hemoglobin. And hemoglobin, of course, it's the main protein of our blood red cells, and it's the one in charge of transporting oxygen from the lungs to every other tissue, the brain, muscles, intestines, all of them. So if we have high levels of glucose, this glucose will stick to hemoglobin, and we will manage to find that sticky or that presence of glucose in our hemoglobin even months after the peak of glucose. So glycated hemoglobin is the average amount, or it tells us the average amount of glucose during the previous 3 months of that patient's lives. That also means that if we have a doctor's appointment and we take a glycated hemoglobin level, even if we, I know on Thursday I will have my doctor's appointment, so I will start taking care of my diet and taking my pills from today, that it's Tuesday. So I buckle my belt, I start behaving really good, and I go to the doctor's office and my plasma glucose might already be normal. So the previous 3 months I was terrible, I didn't do diet, I didn't take my pills. But when I arrive to my doctor's appointment, I have normal plasma glucose levels because the 3 previous days I really behaved. But you cannot fool the same way glycated hemoglobin, since it's giving us our average of the last 3 months. It doesn't matter if you behave these last 3 days, it will tell your physician that you were naughty the past 2 months. This is also a little problem because if we change something in our patient's prescription or diet or something else, we might not see the result in glycated hemoglobin in the short term. So if we give another doctor's appointment to our patient in a week, we will not see any difference in glycated hemoglobin. So it may not give us like a very quick answer of the effect the new pill or the new diet is having on him or her. But plasma glucose is going to be affected really, really quick. So they are both good studies. They are both, and we are about to see specifically what are the levels that we are looking for. But they can be used together depending on what we need to determine in our patient. And now, if we really zoom these two options, these two tests, this is what we might find. These are the things that are called diagnostic criteria, the things that when we find them, the patient has the diagnosis of diabetes. First of all, glucose when fasting. Fasting means 8 hours, previous 8 hours of not eating absolutely anything. They can drink water, but no calories, no glucose, no carbohydrates. So usually we take this test when the patient is waking up to not keep him or her with a lot of hours of fasting. And if we find in that 8-hour fasting patients glucose over 126 milligrams per deciliter, that patient has the diagnosis of diabetes. Number 2, we can find plasma glucose after 2 hours of a challenge, of our glucose challenge. So a test with 75 grams of glucose in water. So it's like a soda, but with a very precise quantity of glucose diluted in it. And of course, it doesn't have other things. It's not a gassy beverage. It just has water and glucose. Some patients like it, some patients dislike it. But with such a high level of glucose that the patient has to take really fast, we wait a while. So we wait for the body to do its magic, to move glucose to storage, to see if insulin works. A normal patient, even if we give such a high dose, relatively high, there are, as I said, some sodas that have even more, but well, this high dose, we expect a healthy patient to storage the excess of glucose and of course have normal levels of glucose, so under 126. If a patient has diabetes, so a lack of insulin function, we will find his or her glucose level over 200 milligrams per deciliter. So we once again have the diagnosis of diabetes. So just to reiterate, if we have a fasting patient, we give him or her 75 grams of glucose dissolved in water, we wait for 2 hours and we find glucose over 200, that patient also has now a diagnosis of diabetes. Number 3, we arrive to glycosylated hemoglobin or glycated hemoglobin. Those are both correct terms. It's also called A1C or HbA1c. If we find it over 6.5, this has the great advantage that we do not need fasting because, of course, once again, this study gives us the average glucose level of the past 3 months. We have, once again, the diagnosis of diabetes in that patient. This has to be done in a certified lab, so we have to make sure that the glycated hemoglobin was properly measured to ensure the diagnosis of diabetes, but in essence, over 6.5 diabetes diagnosis. And finally, one patient that maybe he's fasting, maybe he's not fasting, but has severe symptoms. They are also called classical symptoms, but I would like to point out that these are severe symptoms of diabetes. And hyperglycemia, so over 200 milligrams deciliters, the same as the second point, we have a diagnosis of diabetes. And some of these classic symptoms or severe symptoms are a patient that has polyuria, so he or she goes a lot to pee because he has so much glucose in its blood that it passes to the urine and the urine pulls water, and of course this really makes the patient want to pee all of the time. Hyperphagia, that's a lot of hunger. The patient doesn't feel like he or she are filling up the reserves of glucose, so this induces a lot of hunger. The patient is constantly trying to eat something. Polydipsia, this is a lot of thirst because once again the glucose in blood pulls a lot of water, so the brain feels dehydrated, and finally weight loss, because there is such this imbalance in hormones and hormone production in those patients that they start really dropping the weight very severely, like a ketogenic diet, just like that. So the patient loses a lot of pounds without making any diet. This is also a classic symptom or severe symptom of diabetes. So if we find those classic symptoms, once again, polyuria, polyphagia, polydipsia, and weight loss, with an over 200 milligram deciliter glucose measurement, that's a diagnosis of diabetes. Finally, if the patient has a hyperglycemic crisis, that we will talk in another video about those diseases, but essentially this is the accumulation of ketonic bodies, also called diabetic ketoacidosis, or an hyperglycemic coma. Those are also a diagnostic criteria for diabetes. Now, the problem with glycated hemoglobin, one of the most used studies, because once again it tells us the average of the last 3 months, is that it, of course, depends on our blood red cells. So if we don't have a normal number of red blood cells, we might have a false positive test. So we might think the patient has diabetes, but he or she does not have. Which are the main or the most common diseases of red blood cells that might lead us to a wrong diagnosis, and when, of course, we shouldn't take this test, or we should be very careful when we ask for it. Of course, when the patient has anemia, especially called by hemolysis, something that destroys red blood cells, so falciform anemia, enzymatic deficiencies, maybe a drug that destroyed red blood cells, be very careful with glycated hemoglobin. If we are during a pregnancy, especially in the second and third trimester of that patient's pregnancy, because during pregnancy we have a lot of fluid accumulation even in our blood, so this dilutes the quantity of red blood cells that we will find, and once again it may lead to the diagnosis of diabetes when the patient does not have diabetes. After partum, because we might have loss blood or the destruction of red blood cells. In a patient with hemodialysis, very frequent, because of course one of the main cause of chronic kidney disease is of course diabetes, so be very careful with hemodialysis that once again destroys red blood cells. HIV, a patient with a positive HIV test and that is not properly managed, because a patient with the proper drugs may be indetectable, so that no longer destroys red blood cells, but a patient HIV positive without the proper treatment might be having or experiencing problems with the red blood cells. A patient that we had to put blood in him or her, so when a patient has blood loss, or when we are already treating him or her with a transfusion. And finally, a patient that received erythropoietin. That's of course a drug that induces our bone marrow to produce a larger amount of red blood cells, because the patient of course has very few of them. So all of these diseases, when they are present, just have in the back of your mind, okay, the analysis was made, but it's not so certain, I might need a second test. And of course, also, if we did one of the first tests and there's something that we suspect might be fooling the test, for example, I measured glucose when fasting, but the patient was in the hospital and he had pancreatitis or sepsis or pneumonia or a severe infection. This severe infection, of course, can alter insulin, so when we control the infection, it might disappear the effect. So once again, if we took the test while the patient was on the hospital and it was slightly altered, so for example 128 in fasting conditions, then we probably want to repeat the test. We will repeat the same test, but now under normal conditions. Or if, for example, the patient had a thyroid disease and we found the classical symptoms and a high level of glucose, okay, then we might first correct the thyroid disease and then repeat the same test to determine in normal or much closer to normal conditions if the patient persists with the insulin deficiency. If, of course, the second test is also positive, then the patient, without any doubt, has diabetes, and we have to manage him or her accordingly. If the second test is normal, then we don't lower our guard. We have to repeat another time that test. That is a high-risk patient, and we're about to talk about how to monitor those patients. But we don't start treatment in those patients. We monitor them, and we expect or we wait a little while to see how the body of that patient develops and manages glucose. Also of note, we might have something called prediabetes. We are not going to really dive down here. We will have another video about prediabetes, but essentially prediabetes is not a disease. It's like a very big risk factor, so it does not need pharmacological treatment. This doesn't mean that they don't need anything. They need a very, very strong life-changing intervention, change lifestyle conditions, because the risk that they will get to a diabetes diagnosis is much, much higher than the general population. What are we talking about? A patient with a BMI over 25 kilograms per square meter. This is, of course, an overweight patient. So if we have an overweight patient, this is a diagnosis of prediabetes. And besides being overweight, an additional risk factor. And here we can find lack of physical activity, of course, less than 150 minutes per week doing exercise. This has to be a mild to moderate physical activity, so our heart must be beating over 100 beats per minute. A first degree relative with diabetes, first degree of course defined as my parents, my brothers and sisters, and or my children. So any of that, like such a close connection with a patient with diabetes, is of course a very important risk for myself. A high risk ethnicity, so here we find African Americans, Latins, Native Americans, Asians, and inhabitants of the Pacific Islands. Women who gave birth to neonates with a weight of over 4 kilograms or 8.8 pounds. This is, of course, a macrosomic baby, a very big baby, and they usually are born because of an increase in insulin when they were gestating, when they were being formed. This, of course, is a high-risk pregnancy because it may lead to other complications, but it also tells us that patient's, the mother's body, was not very good at managing glucose and insulin, and it may lead to an increase in insulin, and then the increase in insulin lead to an increase in the mass of the baby. The baby is also at risk of developing further in his or her life obesity and diabetes, but that's of course a topic for another video. We may also find here patients who had the diagnosis of gestational diabetes, so diabetes during pregnancy. Usually a patient with gestational diabetes that was not treated or managed properly will have a macrosomic baby, so a very, very big baby. But there are some cases where we find, or the ideal is we find the gestational diabetes, we manage it, and then the baby does not come or is born macrosomic. So, but we can find one or the other or both in some of the patients. Hypertension over 140 over 90 millimeters of mercury, or being treated for hypertension with normal measurements of arterial tension, a very low, quote-unquote, good cholesterol, so less than 35 milligrams per deciliter, or triglycerides very high, over 250. Women with polycystic ovary syndrome, we already talked about how polycystic ovary syndrome is a sign of insulin resistance. So a patient with insulin resistance that it also has obesity or is overweight, that is a very, very risk factor to develop further down the line diabetes. And this is a patient we have to be very aggressive to curtail those risk factors and protect the patient from arriving at a diabetes diagnosis. Other conditions associated with insulin resistance, we already see or mentioned most of them in the video of Signs You'll Have Diabetes, that I will also leave a link on the right top corner. But these are things like obesity, acanthosis nigricans, polycystic ovary syndrome, others, and a patient with cardiovascular disease or a history of cardiovascular disease. Here we can find, of course, we already said hypertension, but also past infarctions, a stroke, even thrombi formed in any part of the body, like in the lungs, in the legs. Those are history of cardiovascular diseases. that is a patient at high risk, and that we have to be really aggressive with lifestyle interventions to decrease the risk of diabetes further down the line. Now, what's the follow-up? As we said, a patient that is already diagnosed then is in another categories. We have to manage them as diabetic patients or patients with diabetes, and we have to treat them with, of course, diet, physical activity, and many cases give pharmacological therapy to those patients. And we will talk about management of diabetes and follow-up of a patient with diabetes in a next video. However, in patients that do not fill the criteria, for example, they have pre-diabetes or we're just monitoring them, we have to begin screening for diabetes at 45 years old. And since they are 45 years old, if the patient has completely normal results, we have to repeat the tests every 3 years, because of course every year the patient gets older is a year they have a higher risk of developing a diagnosis of diabetes. And in patients with high risk, we have to repeat the tests early. Once again, patients that have the diagnosis of diabetes, there's a series of tests they need to make yearly, and we will talk about them in a next video. And as always, I leave here the references, the sources. So for, of course, the guideline for physicians from the American Diabetes Association, the part about diagnosis and classification of diabetes. I suggest you check it out to know a lot more. It's a little complicated, but it's a really complete document to once again keep the little blue monster in check and have really balanced lives. So that's it for today's video. Thank you very much for watching this video, sharing it, liking it, subscribing, and all the other things. And as always, help us change the world. Share the information.